Friends, this is a uh, small, simple topic of hypertension, or very practical application of this knowledge of hypertension, which we see in our patient, and all of us see patients with hypertension every day. And we are just touching few aspects of the hypertension. In some cases, where we try to use some additional guidelines or the treatment lines which we follow from the international guidelines. So let's go into the little bit detail on the hypertension. Let me think of the prevalence of the hypertension. Hypertension is believed that 1.3 billion people were in 2015 on the statistics, which reached to nearly 1.5 billion and expected to rise up to the 2025. So 150 million only in the Central Europe have been identified for the blood pressure. Interesting fact is that the prevalence of hypertension is in adults is around 30 to 45% in average adult. So this seems to be 1 in 3 or more than that, maybe 1 in 2.5 people can be considered as hypertensive. So every third person which will check in the room may be hypertensive. But if you go to the number of people above the age of 60, then it is almost 60%. And particularly those individuals who are not very active, they are sedentary, and they have weight gain, what we call the couch potatoes. So I think that we have to avoid being overweight and be physically active. That helps. So if you look at the data in 2000 and last years, then it's almost in 2 decades, the difference has further become prominent that ischemic heart disease or a stroke, if we combine and call them as cardiovascular events, then they were #1 killer all over the world. And these are the numbers which has been from WHO given. In fact, other factors has been very minor. Infections has gone down. So this has been a change in last 30, 40 years, which has happened in high blood pressure. So as I mentioned, the various factors which constitute, let us enumerate what are the things which are associated with high blood pressure, like obesity, insulin resistance, what we many times call as metabolic syndrome, high alcohol intake, salt intake, which is very often we take salt. I don't know how many people know about this salt. Why salt? Why we take salt in our diet? Has anybody any idea? Just put in your ideas in your chat box. Let me think what we think. My own theory is in generation before, when we didn't have a refrigerator, salt was a preservative. It was added to the food, meat, and all these items to preserve and keep this thing. Many of the meat items, they still dry it and put in salt and keep it. So that's how many times the salt was used as preservative, and that's how we got into the habit of eating salt. And now it is considered as a must part in the salt as in the diet or any food items. And if salt is not there, it's very difficult for us to taste that food or eat that food. So coming back to the other factors, aging, sedentary lifestyle, stress is a provocative factor or contributory. It's not per se primary cause for the high blood pressure. Usually you may have a reason to have high blood pressure, like a family history, which I believe is very important. If your parents, your grandparents have high blood pressure, there very likelihood that as you grow older with age, one can also get in next generation. Low potassium intake, which is again, it is included with the people, those who have more food which they take a processed food and not fresh food, like fruits contain a lot of potassium, which is a natural way to counteract the sodium, and it helps to reduce the blood pressure naturally. Low calcium intake, hyperthyroidism, drugs, corticosteroid for some reason like dermatitis or some chronic conditions, pulmonary conditions where we use it, contraceptive pills, chemotherapies. All these are the risk factors which increases the blood pressure. Some of the regular risk factors which we all know, but it has been enumerated very long list, which is very useful. And they all lead to heart attack or a stroke, heart failure, or renal disease. These are the major concern which blood pressure leads to. In other words, we have read always in our books, there are target lesions. That means the heart, brain, kidney, and leading to the heart becomes also involved the heart failure and vascular complications. These are the major complications which are related with blood pressure. Now, complications of the heart pressure is the major, as we know, hypertension is the major cause of premature death worldwide. And this is not us. The data has been very well published by the European Society of Cardiology and European Society of Hypertension. And they showed elevated blood pressure was the leading global contributor to premature death in 2015 and accounted almost 10 million deaths. So if you look at the details on your right side in the graph, ischemic heart disease was topper. Almost half of the deaths were because of the ischemic heart disease. And second were the stroke, which could be either hemorrhagic and ischemic. As you understand, ischemic stroke, in other words, is what we call as embolic stroke, and which is more common with either heart failure or atrial fibrillation when blood clot goes to the brain. So as such, this make almost 3/4 of the all deaths which happen with the cardiovascular reasons, and others were only 1.6 million people. So I think it was a major contributor. And what are the risk factors, cardiovascular events which we see in our practice? Hemorrhagic stroke, ischemic or embolic stroke, as we discussed. Atrial fibrillation can happen because of high blood pressure. High blood pressure as such has got raised LV diastolic pressure, which leads to high right atrial, left atrial pressure, and high LA pressure leads to causes of atrial fibrillation, atrial stretch. So these are the sequence how it happens. Myocardial infarction, sudden death, and heart failure, peripheral vascular disease, and many times ischemic heart disease and peripheral vascular disease have combined effect, end stage renal disease, and cognitive decline, function decline, and dementia. So all these are the events or the ways hypertension can affect us. Sorry. If the hypertension is detected early, it is possible to minimize the damage of the target organs, or the risk are heart attack, heart failure, stroke, and kidneys, as we are talking about the target regions. So recently there has been a change in thinking for various guidelines. If you say NICE from the UK, International Society of Hypertension, European Society, Canada Hypertension, and JNC8, all were having 149, 190 diastolic and 140 systolic as the target where one should start considering person to be hypertensive. This will go in detail how to diagnose and how you can make one diagnosis on that. But recent one's guideline, American College of Cardiology and Heart Association, they definitely lower the figure or target, make it more stiff, 130 and 80, for which there has been some question and answer and debate. But if you look at the trials which supported this, it justifies the people between 140 and 130. When they reduce the figure, there has been a number of people who were having events who has a blood pressure between 130 and 40. So obviously the target is stiffer, but probably benefit will be there to protect these patients, or we can call it a window of opportunity to save these patients from the additional events. So how one should go about this approach for the treatment? Sorry. So optimal blood pressure is 120 and 80, which is normal. Anybody should have it. And normal blood pressure from 120 to 129 systolic. If you find in your practice, you should repeat BP every 3 years. So it is maybe a little trend towards blood pressure going up, but it is not hypertensive at all. 130 and 90, this is the European Society, which is earlier than the ACC, and they considered as a high normal, which according to ACC or AHA should be the target for the blood pressure treatment. And obviously at this stage, you need more monitoring, maybe ambulatory and home blood pressure monitoring. This is the new trend or new guidelines which I've seen in and recent guidelines, that outside the hospital, blood pressure measurement may be more reliable marker or indicator of true blood pressure. Because when patient come to hospital, either his blood pressure can be masked, or people become hypertensive, what we call white coat hypertension. So all these things can be avoided if we do out of office measurement, and these patients should be monitored in their European guidelines. So if they come to the target of the blood pressure, still you need to be sure before you start the treatment. The reason is that once you start the treatment, you should not stop it, because many times patients ask this question: I am very young, 35 or 40. Should I take the blood pressure medication? How long should I take the blood pressure medication? When it becomes normal, should I stop it? And many times patients take liberties on their own. When they find the blood pressure is okay, they stop it. And then they will end up maybe after a few months in emergency with a very high blood pressure. So I think even if they will stop the medication, people have a blood pressure, their receptors are reset. So even the blood pressure still remains normal for a few days, sometimes after a few weeks. So it's not the delayed action of medication, it is the resetting of the parameters. Sorry, there's something wrong which is happening. So we have to be careful. We have to explain to the patients that you don't have to stop the medication on your own. It should be with the consultation of your physician, and they have to decide whether they can reduce the medication. Of course, yes, if you have a patient has symptoms, you can reduce the doses, but I would still prefer to give a small dose to avoid rebound. So I just go back to the history. Maybe you have read at the medical school, and for what was the first antihypertensive agent? It was, I didn't know that. It was the diuretics. And you see how important it is to have a good observation. And interestingly, many of the researches have been conducted by not the noted professors, but by the help of the students. And this is a Viennese student whose name was Alfred Vogel. He discovered that patient passing large amount of urine after they had received injection for organomercurial for the treatment of syphilis. In 1940s or before, syphilis, they didn't have any supportive, any stronger antibiotics. So this organomercurials were used for the treatment of syphilis. And these patients were passing very often urine, and that's how he made observation. There's something with the mercurial compound, they affect kidney and they produce too much urine. And that's how for next 20 years, organomercurials were the most potent diuretics at that time in clinical use. Its limitation was it was effective when it is injectable, and it also had toxic side effects. So the diuretics were organomercurials, and some of the herbal diuretic were used before this, which were very ineffective and partially effective only. So if we list at that time, diuretic were herbals initially, or if you remember some of the people when it started, one of the herbal was the Rosarpia or Serpacil, which was used even later on. So then comes the mercurial diuretic, which was for the syphilis I mentioned. Another was the sulfonamide, which inhibited enzyme carbonic anhydrase, and it was in 1940 Cornell University scientist Robert Pitts. He was awarded Nobel Prize, and he was made this discovery. Main problem was this carbonic anhydrase was useful from the diuretic point of view, but it causes acidosis, which was a serious side effect for the large amount of using of sulfonamides. Then at that time, there was a need for some better diuretic, and the second generation diuretic was hydrochlorothiazide. Interestingly, still it is used in clinical practice, and it was basically used not as a diuretic for the only heart failure, but also as a treatment of blood pressure. MSD and SIBA, or Merck and SIBA, were jointly conducted this research, and MSD really made money, more than 20 billion, from this one product, diurel, which was the hydrochlorothiazide. So in 1950s, prolongation of the survival in patients who were treated with the diuretics for hypertension was realized. So this is practically was the first treatment or effective treatment of hypertension, which could prevent, reverse or reduce the major events or hard points. In 1959, American Heart Association or National Institute of Health from US all reported declining death rate attributable to new antihypertensive thiothiazide. And people have started thinking why we should give these agents at late stage, why we should not start at early stage treating the hypertension. So as you have some new drug comes, we always are worried for the side effect, and it was the case for thiazides as well. Then came the usual concept which we are using in practice, guideline directed therapy. And if you look at the European Society guidelines, they clearly demonstrated core drug treatment strategy for uncomplicated hypertension. And as I showed you in initial chart, is the blood pressure when it is on a moderately serious note, then you can start right away a combination therapy. One of the important part is the ACE inhibitor or angiotensin receptor blockers or ARB. One of the two is the one component, and the second part of the component of the combined pill could be calcium channel blocker or diuretic. So diuretic per se, we have seen very effective in controlling blood pressure, although diuretics have some side effects, but still they are very effective and should be used particularly in certain populations. For example, calcium channel blocker and diuretics are very effective in blacks, and that genetic background should be in mind when you're treating a patient. Obviously, when it's not effective, you can go to the step 2. You can make a triple combination, ACE or ARB plus calcium channel blocker plus diuretic, all in one pill. The reason why this one pill concept came, because the adherence to the treatment is much more. If we give 3 pills to the patient, invariably patients on their own, they stop some of the pills on their own sweet will. So that's the one thing which you have to keep in mind. And many of the patients, when they come to see the doctor, they go back and many times keep on buying drugs on their own. They don't even come for the follow-up. So you are lost the follow-up these patients, and they may not be having adequate treatment for various reasons, either cost or reservation for taking medicine or the possibility of the side effect of the medication. These are the reasons why patients stops medication on their own. If the patient is not controlled with these 3 drugs, they are called as resistant hypertension, and you need to add additional agents. MRN, which is a spironolactone or potassium conserving diuretic, and which is in addition to, you can always also add alpha or beta blockers. If you remember in 80s, beta blocker was on forefront for the treatment of ischemic heart disease, for the treatment of blood pressure. Now it has gone into the back seat. It is almost as last resort or last treatment or drug which we use when others have been failed, except certain situations. Like if it is ischemic heart disease, then you prefer to use beta blockers or calcium channel blockers because it helps to control angina and ischemic heart disease. Or it also helps in presence of atrial fibrillation to reduce the heart rate. So these are the few situations when beta blockers are preferred. So let's start with a simple case from my clinic. A 55 years female referred to cardiology with intermittently or high BP recordings and dyspnea. She was newly diagnosed uncontrolled hypertension after multiple office BP recordings and persistently high recording on ambulatory BP monitor, which is almost, I believe, is a very important part of armamentarium. And we try to do this investigation more often than before after the new guidelines, because it gives a much clearer indication. And I feel another way, from another point of view, from the psychology of the patient. Patients are always, when newly diagnosed, they are in denial phase. They don't want to accept the drug treatment. Of course, you can convince them to take the lifestyle modification, active life, avoid sedentary life, avoid risk factors, and they want to do yoga, meditation, other natural means to reduce blood pressure, but not to take medications. Then I think it is our duty for, as a clinician, to emphasize the need of the treatment. Why? Because they can reduce the complications. I think that we are not just here to reduce the numbers. Number of blood pressure makes a difference, but what it makes more difference is the end result or the end point. And if they understand what could be the damage it can do, probably they understand. And if they ambulatory blood pressure, they see the blood pressure has gone in the night, which they should not have a higher level when they are resting. So they are easily, we can convince them that medicine should be taken. So she also had a comorbidities, diabetes type 2. She had a mild nephropathy and heart failure. So the drug treatment strategy, which is very simple, it has to be ACE or ARB, one of the two, not two together. Although I just let you know that some physician used it in combination. It did not have offer much except slight improvement in the blood pressure, but more side effects improved because the potassium levels rise and kidney failure increased. And I think at some stage, if you do that, you should involve in your treatment one of the nephrologists. I would recommend not to use together. So initial therapy was in this patient was ACE plus diuretic. Diuretic preferably is loop diuretic in initial stage when patient have a heart failure. Personally, I prefer in long term, you can change to hydrochlorothiazide, which is longer acting and have a round the clock effect of the sodium reduction from the system. And beta blocker was given. Any patient with go to the heart failure side, beta blocker have shown long-term benefit in terms of reduced mortality. So if that was not effective, our approach should be, step 2 should be ACE ARB plus diuretic or beta blocker and MRA. So these drugs are the way this patient should be treated. And if patients, some of patients, as this patient was ACE, kept on ACE, and she could not tolerate because of the cough. Cough is a known side effect of the ACE. So it was changed to olmesartan, which has proven superiority as compared to other ARBs. Here it shows the effect on diastolic blood pressure after 8 weeks of treatment, which was reduced by 8.5% millimeters of Hg as compared to valsartan, which is less effective in reducing. In the same way, it was the reduction in the systolic blood pressure from irbesartan was next to olmesartan. So obviously, you should use one of the therapies which is more effective in the blood reduction of the efficacy. It is another way when they compared candesartan and telmisartan, and the difference is shown in here, and both the achievement of the target rate reduction, which I've seen in these two slides. Let's come back to another patient. A 45-year male presented in emergency with acute ST elevation myocardial infarction. As a standard practice, managed with primary PCI of left anterior descending artery with a stent. His comorbidities were hypertension, heart failure or early heart failure, LV diastolic dysfunction, pre-diabetic status, and hyperlipidemia. So this patient also was high-risk subject, and the question is, what else should be done after angioplasty? If you look at the literature in acute myocardial infarction, there is a data to suggest the valsartan or ARB has been effective or as effective as captopril, and the combination has been tried. So these three groups were used, either captopril, valsartan, or combined valsartan and captopril. And valsartan was very effective in terms of reducing events, and that's what we are concerned in terms of the reduction in the hospitalization for angina. So after acute MI, one of the ARB is as effective, and ARBs came later after ACE. Initially, as we look at the old treatment in the 80s, it used to be beta blockers, and ACE inhibitors came, and then in some patients, ACE were replaced by one of the sartans or what you call ARBs. So if you look at the value study in the post ad hoc analysis, it was shown it was as effective as amlodipine in prevention of a stroke and cardiovascular adverse event. And this here clearly shown in this diagram, and where you can see it favors valsartan as compared to amlodipine in some of the areas. Value study also had an interesting point, which is the new onset diabetes was reduced in the group of patient who used valsartan as compared to the group who was using amlodipine. So ARBs and ACE both have been reported to some extent the delayed onset of diabetes or reduced event of diabetes in the subgroup. SMART trial was very interesting data where Vanguard or valsartan significantly reduced microalbuminuria as compared to amlodipine, which was 18% more, while the minus 32% decrease when they used valsartan 80 to 160 milligram. So these are the additional benefit of this drug in addition to reducing the blood pressure. And as I mentioned, we are trying to look for the target organ, and microalbuminuria is the first indication of the kidney damage. And if you stop at this stage, probably you can stop the end-stage renal disease to occur at all, or at least delay. In another study, WellHaft, which is the post-hoc analysis, which showed in heart failure subgroup of patients, there has been significant improvement as compared to placebo. The risk event reduction rate was 44%, which is significant in this subgroup in the study. And that also helps us to say that this drug could be of use in our patient who has been ischemic heart disease and has other comorbidities, as I mentioned before. So treatment in our patient was treated with valsartan, titrated dose, time-tested forced diuretic hydrochlorothiazide for the better control of blood pressure in a combination at the discharge and with anti-diabetic medications. So these were the treatment which he received, and this was all based on the guidelines as we mentioned, or I mentioned in the few studies just above. So another aspect of this patient who is ischemic heart disease, our aim is also look after for the cholesterols and LDL targets, which helps in reducing this subsequent event. It is well known if somebody has got one coronary event, he has at least 20 to 25% chance of having second event in fairly short period. And that comes into the very high risk subgroup or high risk subgroup. I will not go the details, but all you know mostly, and this chart or slide has been used very often. So this medication which he received was dual antiplatelet agent, loop diuretic plus spironolactone, valsartan, statin, and later on ezetimibe was added to keep the LDL target of less than 70 according to the guidelines which we usually use. So if this chart is very useful, which differentiate from the score way of scoring the severity of disease and side effect and the high risk profile. And if the patient, our patient, have somewhere between very high to high risk profile, so our target should be 1.5 millimole or 55 milligrams to 70 milligrams, somewhere in between. So if you go through all the major factors, you can work out where your patient stands and what should be our target. And our target is getting stiffer and stiffer. And if you look at the newer studies, they are still going less than 55. And there was a question mark whether we can bring LDL to zero and whether this will provide more reduction in the events. So that's time has to say what that level will be. So drug treatment strategy for hypertension in a patient with coronary artery disease, as per European guideline, has been ACE or ARB, which we have used, plus calcium channel blocker or diuretic. Here with diuretic was used. Step 2 was combination. And then if the patient would have been in the resistant, then we follow this schema of the treatment. Drug treatment strategy for hypertension and subgroup of patient with atrial fibrillation, that takes special attention because atrial fibrillation will further reduce the output of the cardiac output and leads more complication like thrombus formation, and which could lead to embolization or embolic stroke. So our challenge is much more in these subgroups, and here the beta blocker becomes an important part. If calcium channel blocker, it has to be non-DHP calcium blockers, not the nifedipine, but amlodipine, nicardipine, or diltiazem, where they can reduce the heart rate. This particular subgroup is useful. Beta blocker plus calcium channel has been used, but this combination has to be used with a lot of caution because they can cause a complete heart block. So these are the mechanism way in the patient subgroup according to European guidelines where you can use it. So management hypertension in high-risk patient. The care of high-risk hypertensive patient is directed manifold, covering additional risk factors: uncontrolled hypertension, heart failure, renal impairment, stiff LDL targets have reached, and all have to be addressed in addition to standard of care as per the guidelines. Thank you very much.